Okay, so welcome and thank you for joining us. This is session 5C, slow release oral morphine as opiate agonist therapy in the fentanyl era, a qualitative study of client experiences. My name is Darren Greer, and I am the moderator for this session. Before I introduce our speakers and we start the session, just a couple of reminders. The session is being recorded. If you have any questions during the session, please enter them into the Q&A box and I'll deliver it to the speakers once the presentation is over. You can add comments in the chat, but please make sure that you add any questions in the Q&A box and not in the chat. Once the presentation is over, you can also raise your hand if you like and ask the speaker a question directly. Now I'll introduce the speakers for the session. Dr. Pamela Leece practices clinically in substance use at Women's College Hospital, The Works, and Kickstart Medical. She also works as a consulting public health physician with the Health Promotion, Chronic Disease, and Injury Prevention Department of Public Health, Ontario. She is an assistant professor cross-appointed with the Department of Family and Community Medicine and Dalla Lana School of Public Health at the University of Toronto. Her current work as a WIHV Innovation Fellow at Women's College Hospital. Her research focuses on population health and health systems research on substance use. Ashley Smoke is the team leader of the Red Path Project at the Native Women's Association of Canada. She's co-founder of the Ontario Network of People Who Use Drugs, lived experience engagement consultant with the Public Health Agency of Canada, and co-chair of Health Canada's People with Lived and Living Experience of Substance Use Council, among other positions and research affiliations. Welcome, Pamela and Ashley.
Thanks, Darren. I'll quickly share the slides and go through our administrative pieces, and then Ashley is speaking first. Darren, does that look okay?
Yeah, it looks great.
So just for our disclosures, the project we're speaking about has Ministry of Health funding from the AFP Innovation Fund. Also for potential conflicts of interest, our collaborators, Jennifer Wyman and Ashley Smoke, were part of the development of the guidelines that we'll be discussing from Medify around slow release oral morphine. And just to go to the next slide. As shared in the introductions for both of our presenters today, we have our employment affiliations, and then I also have received grant funding from CHR, Health Canada, Public Health Agency of Canada, and Ashley was part of many of those projects as well. Just to mitigating our potential biases, as I said, with the co-authorship on the team for the guidelines that we'll be discussing, we also have a large, diverse collaboration on the project, and most of the investigators weren't involved in the development of the guideline and provide various perspectives to kind of conduct and analyze and interpret our information in an objective way. So just for our acknowledgements to begin, we want to acknowledge the land, people who use drugs, our broader team, and our funder. And I'm presenting from Scarborough, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and Haudenosaunee and Wendat people, and is now home to many First Nations, Inuit, and Métis people. I'm committed in my personal and professional life to doing my own work and reflection around learning the truth and committing to reconciliation in the work that I do, and also acknowledging the strengths and innovations of people who use drugs and the leadership, particularly at this time where there's, the involvement in the community is so important in order to have a way forward in the toxic drug crisis. Ashley, I don't know if you wanted to say anything just as part of the acknowledgements or just when you begin your section. So for our learning objectives, we'll describe the context for our qualitative study of slow release oral morphine, We'll summarize the study design. This is a work in progress. We'll give you some hot off the press preliminary results, and then we'll discuss the implications of the study findings for policy change and promoting retention in OAT care, which is part of the conversation around the guidelines and practice in this area. We'll just ask if you wanted to put any initial thoughts for conversation among the group in the chat rather than the Q&A for the end of the session. You can share with each other how you currently feel about prescribing SROM and just have a little chat conversation going as we begin. So I'll turn it over to Ashley here, and we'll just check your audio, and looking forward to giving the context around slow release oral morphine. It's just a little hard. I can't hear you yet, Ashley.
Can you hear me now?
Yes, yeah, perfect.
I think something changed between now and then. Okay, so I guess my name's Ashley Smoke. I guess I'll just start with an acknowledgement of the land we're on and acknowledging that, you know, the seasons are moving as we are moving through treatments in OAT. We're moving from winter to spring and back to winter and back to spring. We don't really know what it's like. So I just want to thank Creator for giving us these unknowns and these days to reflect upon and letting us see the sunshine in between. I like these rainy days. I don't know if it's rainy everywhere where everyone is, but on these rainy days, I really reflect on the people we've lost and the strides that we've made and the things that we need to still work on, because I spend a lot of time just staring outside for some reason. So a lot of things come to mind. And this morning when I was just looking out there, a lot of people came to my mind, and I don't know why. Maybe they knew I was doing this, the spirits that follow me, who knows. But I like to thank Creator for those spirits and those energies that follow me and give me the strength to do this work every day. So I have lived experience with a lot of different treatments in OAT. And I've met a lot of people through my work in community who have a lot of experience with fentanyl and accessing OAT treatments. And what I've noticed in community and my own experiences is that when fentanyl came in, and also like with the benzos added into the supply, people's tolerances really shifted and OAT was less effective, like I guess anecdotally for people. And I've noticed that people started taking methadone more for like overdose prevention more so than withdrawal relief. Like for myself, I would take methadone even though it wasn't doing anything for me, but I didn't overdose because of it. So I just kept taking it even though I felt like it was ineffective. So I think it's really important to acknowledge that people sometimes are just like, they're not even getting withdrawal relief from methadone with this fentanyl era. So also people, because people need to ask for increases because of fentanyl, a lot of people were like feel very judged when they ask for things like SROM or Dilaudid or anything that's not methadone, Suboxone, and that kind of like first line treatment. So a lot of people that I've talked to over the past few years have really felt like when they ask for different treatments, they feel like they're identified as drug seekers. But then when they don't ask, they go through withdrawal, and if they don't take fentanyl, that gets even worse. So it really created this dynamic where people were leaving treatment a lot, or like very sporadic in the way that they access treatment. So we had to have a lot of conversations about that. And the rules of the programs were not responding to our current needs with the fentanyl. There's like a max dose for methadone. I'm sure many of you know this, but like most of the time they kind of top you at around 120 previously. And though because the doses are too low. Oh, sorry, I don't know what I just lost my whole train of thought. Anyways, so yeah, the rules weren't responding to the updated needs. The max doses were too low. People's urine screens aren't reflective of their actual use. Like I know people who actually stopped using, and their fentanyl was in their system for 45 days plus. So like, I don't know why that happens for some people and not others, or what the case is, but it just, like, the urine screens weren't reflective of people's actual use necessarily. And then SROM added to methadone provided people a lot of relief from the withdrawal when they added it to methadone or other things. Gave them more energy. I heard people feeling like they were going to use it to like get off of methadone as like a way to like get in between medications. So there's different uses for it throughout the fentanyl era. We can go to the next slide. Yeah. And then community experiences. So people feel like SROM, in like my experience talking with people, obviously, people felt like SROM provides stability, and that we need more supports and like wraparound services like housing, parenting, and wellness, like strategies mixed within that kind of care. There's cultural safety issues. There's racism still in our healthcare system. There's a lack of cultural awareness that persists. Take-home access to carries is very, or to medications is very like all over the place. You don't know from one clinic to the next what the procedure is. Every doctor is different. It's very inconsistent. So and yeah, you might not even have a care provider depending on where you are. So people also really want choice. They don't want control. Like, people want autonomy over their healthcare. ONPUT has done a lot of projects with people who use drugs, one with ER, with emergency rooms, and we really noticed that people want to be in charge of their healthcare. They want to feel like they know what's wrong with them. They want to actually address the issues, but there's a lot of stigma that prevents that. So pharmacy experiences also, people have identified to me that they're less stigmatizing when people go to the pharmacy and they're accessing SROM over methadone. So that is something that I've noticed even myself. But there's also, it's more discreet too. Like, people won't see you getting a witness dose necessarily. They see you taking a medication. It doesn't look as stigmatizing. So also there's misinformation and inhumane policies, backlash against safer supply and different medications that are newer or less, like, not first line treatments. So this backlash has created barriers to access, barriers to information, disruption to care and treatment. And this was unsafe for people with lived experience. So we go to the next slide. So basically, throughout all of my experience, I've learned all of that stuff. And I've been working on different projects with, you know, Pam and the ODPRN and Jen Wyman and Medify. And one thing that came up time and time again is that there's a lot of data with numbers. There's a lot of literature out there, but most of it, when we're creating guidelines or when we're writing reports, a lot of times what comes up time and time again is that people's experiences are the thing that's lacking in all of the evidence. So when we're trying to make guidelines or trying to write reports, we're trying to figure out what this data means, and the answer is really right there in the people's experiences, but we need to find out what those experiences are, and there's not that much literature out there to explain this. So me and other people who use drugs, I'm sure we've all harped on this point of qualitative research is very important. So I think through realizing all of this, projects like this came into fruition. And also we were also writing the guidelines around SROM and realizing that people's experiences were different in every different kind of site. And so we wanted to really see, like, what are people's experiences? How are the SROM prescribers running things? Like, are people getting wraparound care? And I've also noticed the difference between methadone clinics and community health centers, and the wraparound supports and the importance of wellness. So there was really like this contrast between what was offered. And so I think it's really important that we see how different clinics run, what people's experiences are, and how that all plays into access and care. So we advocated with others that these guidelines need to reflect the experiences of people. And so now we're doing this project. So we need options as people with lived experience. We're all different. There's no one size fits all option. Choice is care. What works for one person might not work for everyone. OAT shouldn't be like something that you're on and then stuck on it forever. If you should choose to go between medications, off medications, on medications, you should be able to do that with freedom. I believe, and I've heard this from others, that SROM, different safer opioid supply options, OAT, prescribed alternatives, whatever you want to call them, all of the different medications that provide opioid assistant treatment should be side by side line, not first line, second line, third line, because different people use different medications and they might have different rankings of how they impact them that don't fit with the regular society's model. So also, from what I've read, the community care models of things are very strong with the outcomes that they have with people's experiences. And people need to be able to choose and have the freedom to own their health to achieve their wellness. So we want to figure out if that's happening and how we can make it happen. So we did these guidelines, and one thing, like I said, they need to really reflect the lived experiences of people. But one thing I noticed is that we needed evidence to justify the guidelines, but we didn't have the evidence to justify the guidelines, so then we couldn't push the envelope as we needed to. And I think that's where my that's where my thing, like my issue came up every time, was like, how do we create guidelines without evidence if we can't create the evidence? So we're creating the evidence. And then also we have to center those guidelines in lived experience and the experiences of those people. So we shouldn't just be an afterthought. It's important that different guidelines are created with people who use drugs from the start. We when we just created this guidance document, and there were like rules that there were different punitive rules before, like no carries and daily dispenses and constant UDSs, and that just breaks trust. So our newer guidance is, we have like higher starting doses, and we have things in there about rapid titration and recommendations on carries and pregnancy, and we have a patient decision aid. Like that guidance document to me was like my pride and joy, actually. Like I really appreciate all of the change that I've seen in it, but it was really hard to make that change without the evidence. So we really need evidence, but we also need the experiences of people who use drugs. And that's why it's important.
Thanks so much, Ashley. So just if you wanted to add in the chat from the audience here, what would you want to know from people prescribed SROM in your own work to be able to influence your practice? And you can add to the chat and create some conversation. I'll go ahead and let you know how the study's going so far. So Ashley set the foundation for, the work around the guidelines and why they're needed. And just as a quick overview, there's guidelines now for SROM as monotherapy, being offered as a treatment option, and can be comparable to methadone, and gives people a different option, and using it to convert from other OAT, as Ashley mentioned, and take-home doses are based on stability and safety in the current guideline. Then there's the guideline for people who use fentanyl and being able to combine with the current, with the standard methadone treatment. So it may have higher retention for people, is the intention. It's slow starting methadone to be able to get to the dose that you need, as Ashley mentioned. And so there's now co-prescribing of SROM at the same time as methadone. And then there's considerations in those guidelines around some of the things that Ashley was mentioning as well, being able to extend people's prescriptions when they're unable to attend appointments, having a review of the urine drug screen and visit requirements, being able to be comprehensive, treating mental health, and also integrating harm reduction into the work with people who are using fentanyl. Our study objectives are listed here. We have part of our work is describing the patterns of SROM among the people that we're interviewing, just as a sort of an overview. And then we have 3 areas that we're asking the qualitative questions. So what's the effect of SROM? What's your experience accessing it as a program or a treatment option? And then exploring perspectives on the clinical and policy changes that could help with the guidelines and care, promoting retention for people in OAT treatment. So our design is mainly the qualitative study. We're using semi-structured interviews We're located in Toronto for the interviews of 30 participants and seeking a diverse group with perspectives and experiences with SROM. And then we have an interviewer administered questionnaire that goes along with it, just to be able to describe among the group interviewed their medication use currently, and then the demographics of this group. The inclusion and exclusion criteria are here, and the only exclusions we have around some subgroups of people that would experience their treatment differently if they're pregnant, incarcerated, or part of a safer supply program. We didn't feel we could do justice to subgroups in a small sample size here, so we had that as an exclusion. So looking for people who are in OAT model using SROM. We'll roll out our recruitment more as we go along this month through Medify and OnPud and CHCs, harm reduction, and OAT clinics. We have community researchers involved to work in the community setting for the interviews. We're being flexible whether people can participate by Zoom or phone or in person. In-person locations would be somewhere as a service agency or somewhere in the community that's already comfortable and familiar for people. And we have an honoraria that also is flexible in how people receive it, by cash or gift card or bank deposit. The interview questions are just listed here as an overview. There's sort of 8 areas that we're checking in on. I won't spend a lot of time here because we'll get into some of the quotes that come from the responses that we have as preliminary results. But again, hearing about people's experience, their goals for treatment, how is it at the pharmacy, how is it with carries, what factors make you recommend SROM or not to others, and how is it in the context of OAT generally, and what advice do you have for programs and policy? And then just a brief overview, the demographics and medication questions that we're collecting are around the length of treatment and dose, other medications they're on and past treatments, and then their overall time in treatment and the settings where they receive treatment, might be in the community clinics or primary care at RAMs or in hospital clinics. And the demographics around age and gender, housing, criminal justice system involvement, and racialization. So most of our data is qualitative. It will be all analyzed together thematically, and then we'll present descriptive statistics of the quantitative data. So some preliminary quotes from our qualitative before we get into more theming. Just to give a sense of when people talk about their experience on SROM, a lot of what's coming through is that it keeps me level, it makes me feel normal, and just about being steady with a long-acting medication is what we're hearing so far. People's goals might differ. It might be that people are using SROM to get off of other things, either prescribed or non-prescribed opioids. And then also hearing the idea that's linked to that second guideline about if you're not able to get comfortable on methadone using the traditional approach, that it can be added to increase people's comfort. The pharmacy experience, and this is kind of reflecting in comparison to methadone, it's sort of, for people are expressing that it's a bit of the same hassle, and getting to the pharmacy when you need to go is you're already waking up not feeling great and needing to go to the pharmacy. And also the practical piece around SROM when the capsules are being opened in the pharmacy and having to sprinkle it on applesauce or a pudding, and sometimes it sticks to the cup, and just the practical issues of just administering the medication at the pharmacy. For take-home doses, I think we're hearing a range of people's experiences. If, and depending on their living conditions, some people may not feel safe having carries, and other people may want to take their medication. And then also hearing around the context for people, it's inconvenient to go to the pharmacy, especially if you're working, and it really should be up to discussion between the patient and the doctor. Recommending it to others, some of the context, especially with the tolerance now that Ashley was mentioning, is that, if you're in a situation where you're kind of maxed out on methadone, or if you can't stop and you want to stop other opioids and need more support, adding SROM can be useful in that case. And for the experience of OAT in general, and comparing between SROM and methadone, some people say that the withdrawal is not as bad. And just overall having access to OAT and treatments that work for you, being able to, have a prescription that helps you from feeling like stops you from feeling sick is a big relief. And the advice to programs and policy and guideline development, as Ashley was mentioning too, what we're hearing from people is that we need access to SROM. It needs to be an option, that the carry policy should be up to the person. Urine drug screens can be really humiliating. The rules need to be reviewed, and that we need to be patient-centered with that. And the option with the administration that I mentioned at the pharmacy, the option to just be able to swallow the pills and not open them if you're having difficulty with that. So the next steps for us are really going to be completing our data collection, having the conversations around the theming, and being able to interpret with the entire team and their perspectives for reporting our results, and then being able to point to some recommendations for programs and policy in this area, informed by our results. That, as Ashley was saying, it was lacking in this area, understanding experiences from people in order to keep evolving the guidelines. So I'll turn it back to Ashley, and people can add to the chat. How do you think research on SROM, or particularly the qualitative research, how can it have an impact for you and practice and structures for being able to access SROM? So back to Ashley.
So I think we've already talked about this, but why qualitative research or data is important to us in community, especially, is that the numbers don't capture what it feels like to be cut off the meds, or to like show up at the pharmacy and not have a prescription there and have the doctor be off for the weekend. And like there's a lot of things that those numbers might capture a piece of the puzzle, but they don't capture the whole story. And these stories, when we put them together, they can help explain like why people drop out of care or make the treatment decisions and the prescription decisions that they make. And that can help inform future practice. So I think qualitative research also breaks stigma, because it shows the truth. It shows, like, those quotes are humanizing. They show the experience. They're indicative of someone's like human experience, and then we can all relate to that. And that's how we move the mark. That's how we make an impact. That's how we can make change. So also, when you use words over numbers, it teaches the clinicians about how we feel about our experiences when like we're forced to change doctors or prescriptions because of policies and different things. And there's a lot of that like policy change happening right now, so it might be kind of interesting to see like are people's access changing and whatnot with policy changes. Also, truths are medicine. So as people who use drugs, our voice is what our I've worked with so many women in prison, and the one thing all of them say is that their voice, like getting back their voice, is what is the thing that healed them. And so when you give someone that chance to share their experience, you give them power back, and getting that power back is healing, and it helps them improve like their own life and want better for themselves, and that in turn helps their treatment, and like it's just like a cycle. So by providing people platforms to share their experiences that are also legitimated by academia and research, I think that it gives people like, yeah, it empowers people to know that they're not alone. There's other people out there that feel like them, and there's things that they can do to advocate for themselves and others. So also, everything always comes back to qualitative data in the end. Like we just explained, we did a lot of literature reviews, worked on different guidance, but in the end, we really needed that qualitative experience. A lot of research on like overdose deaths focuses in on the numbers, but then come to us to fill in the stories of why those numbers are the way they are. So there's a lot of, yeah, we fill in a lot of missing pieces, and qualitative data really like comes in and helps us answer a lot of questions. But there's also a lot of like delegitimizing of qualitative data and calling it like anecdotal and that kind of thing. And when we prioritize quantitative data over qualitative data, we're also delegitimizing it in a way. So that's why it's important to like use both together to tell the story. And it also helps us get our experiences on paper and like out there in the world for other people to read. Whereas because people who use drugs are often so stigmatized, it's hard to get people to listen. So it's a good way to like get people's stories out there in a way that they don't have to face stigma and discrimination and all of that kind of thing. So yeah. Also, I think next one, we went backwards. Okay, yeah. So also we in community, we've been like subjects. So and now a lot of us are becoming like researchers and peer. So like we're using peer interviewing in this project, and this project is like led or like co-led by people who use drugs, and OnPut helped develop the project. So it's really like community driven. It's a really community driven research project, in my opinion. And I think it's important to have peer led or community led research because it's important to answer our questions, not just the institutional questions that come up, but like what questions we have about SROM. So by having us as part of the project, it ensures that people's experiences are at the center and that the research informs how we think about OAT healthcare in the future and what is going to be good for us. So, yeah. And also to ensure that people's stories are honored in a good way. So we w- our like the community led vision for SROM is that OAT is embedded in like community health centers, private clinics, all kinds of different options that people prescribe with care, not punitive measures, that prescribers build relationships and not surveillance systems, that wraparound care is provided, even cultural wraparound care. Primary care should also feel like a home base, not a trap. So like it should feel like healthcare. It shouldn't feel like you're just there as a number, or like you'll never get better because like, you know, there's no progress being made because there's no access. So yeah. Also patient directed um care is really important, and it lets patients choose their path, and forcing abstinence really is detrimental to a lot of people's sobrieties and journeys. So yeah, it's important to have patient-led care, and that all of this all of the access issues, a lot of it stems from not having a primary care provider. So if we had OAT in primary care, that would help with a lot. Like the doctors would just know you better. It's just a better circumstance all around. So that's what my vision is and what I've heard from community. But yeah, the real impact is that the stories are calls for change. They're not just like data points. We'll find all of the issues, all of the, well, not all of the issues, but issues and solutions. And we hope that the research can help change policy, shift practice, and humanize the care that people experience, but also inform like the future guidance about SROM because there's not a lot of it. And then also acknowledging people who have these experiences so they can move forward. Yeah, because like they're the experts and the evidence and the future and all the things. So we really need to center the research and the work around the people that we're working with and empower them to advocate for their health by amplifying their experiences and helping them inform and change the way that we deliver OAT from like a destigmatized, non-judgmental view.
Thanks so much, Ashley. So we wanted to list our team members here. It's a large, diverse team. My contact is there if people want to follow up after with emails. And then we also have some key resources, just being those two guidelines. And there's lots of other past research that's informing this, and new research we're producing. So I will stop the slide sharing, and we can take some questions for the next 15 minutes. And thanks for coming.
Thank you both for an excellent presentation. Just a reminder, you can put your questions in the Q&A at the bottom of your screen. You'll see the box for the Q&A, or alternatively, you can just raise your hand and I will click unmute. Does anyone have any questions? Okay, we as of yet have no questions in the Q&A. Just leave it a little bit. We have about 10 minutes for questions and answers.
My boss always says I can stay here with an awkward silence all day.
Absolutely.
How far are we into this project?
Oh, we have a question. We have several. Yes. So, how far are we? So one of the questions is, how far are you into this project?
Yeah, the liftoff took quite a while getting approvals for community-based research and all of that set. So we're really excited. We started our data collection last week and this week, and we still have the majority of the interviews to still do. We'll be hopefully able to present some more in the fall. We're applying for presenting at CSAM as well. But yeah, we'll try to analyze it quickly once the interviews are finished. They should be done by the summer for us to be able to analyze and present in the fall.
Okay. This one from Ashley. Can you provide any recommendations around timelines of a patient gaining carries for SROM? And that's
I wonder, Ashley, do you want to speak to this first, and then I can follow up? Just being person centered, I think, was the message we were talking about.
Yeah, see, this is one thing that's because there's not a lot of guidance around this. It's like one of those kind of like topics that no, there's not like a consensus, I guess you could say, on this answer. In like I guess the prescriber community all the time. But for for people who use drugs, like I think in my experience, getting SROM, like I think it should be like an automatic carry. Like I think it should be like given like every other medication. You go to the pharmacy, you pick up the bottle for the week or the month, and then you take it as prescribed, just like every other medication. But because of policies and surveillance, I think like a month, like four weeks is usually like what they do for methadone, and I think even that can be cumbersome or like hard to get to. But yeah, 4 to 6 weeks is roughly standard and I guess safest. But I yeah, I've never seen that much of a risk. I think personally, my biggest risk was more like, is the medication stored properly, and asking like those other questions about the carry, like knowing the person's circumstance at home, like if they're homeless or if they have kids, like, and then addressing those things and having those conversations instead of like making a punitive, like, this is the rules, we're gonna give you carries after 4 weeks of being sober. And like I think it would be more useful if you just provided the carries, especially for SROM, because people see you taking the medication at the pharmacy and they're like, why are you taking that here? So I think it would be just more beneficial to give it to somebody as a prescription normally, and then have those other conversations of why you would want it witnessed in the first place. So yeah.
Yeah, I think clinically, in my current experience, there's a full range. Like people may be not sure about tolerance or drowsiness, and like closer monitoring at the beginning, even the medication safety, as Ashley mentioned. And there might be people right away from the beginning with work or mobility or hours of a pharmacy in their area, where they're feeling comfortable to go, that we need to problem solve from the beginning around you know, what we're doing with carries to be able to make it work. I think that was, you know, sort of the main conversation, is just how can this work for you and be safe.
Okay, are there any other questions for Pamela and Ashley? Again, you can raise your hand directly and I'll click on you to unmute you, or again, put it in the Q&A. We have about 6 or 7 minutes left, so we have some time if there are further questions. If not, we can close the presentation. Hey, thank you both so much, Pamela and Ashley. I have pasted a link for a survey to assess the session in the chat. You'll see it there. And the next panel discussion starts at 11 a.m. So it's about a 20-minute break from here to there. And again, thank you both so much for your presentations, and we'll see you at the next panel.